And Dr. Casanova, as a palliative care specialist, pain management, I can assume, is an important part of your toolkit in caring for your patients. And we want a program that works for patients, so legitimate patients are getting the pain medications you feel they need to manage their situation. What are some of the important things that you would ask Dr. Schade to take the advisory committee in regards to making sure that illegitimate patients don't get medications we don't want them to have, but legitimate patients do continue to get the care that you want them to have?
Well, I think that's a great question, and you've touched on part of it. Is the rules that they've implemented are that if you are prescribing medication for a patient who has cancer, and therefore cancer-related pain, if you make a notation of that on your prescription, that eases some of the burden or eases some of the scrutiny that patient and their prescription undergoes. The other factor, however, is the ability to deputize office personnel. So in terms of making this as efficient as possible, being able to deputize via the PMP website an office manager, a nurse, a medical assistant to aid you in screening the PMP and ensuring that there are no unscrupulous activities. Now, another factor of the PMP is not just the ability to screen and ascertain from a physician perspective or a pharmacy perspective, is patient X getting multiple prescriptions from multiple physicians and multiple different pharmacies? Or are they filling early? Are they filling too soon? The other thing that's embedded in this process is an algorithm that, in theory, sort of gives a patient a risk score. Now, from a safety perspective, this assessment is a risk score for risk of oversedation or unintended consequences. But as with most risk assessments, there are in fact unintended consequences. And what I have personal concern about and related to the patient population we see in palliative care, but even in a broader patient population, are the fact, for example, one of the red flags is, does a patient have 5 or more physicians? I think many of our DCMS members understand that we share patients with 6 or 7 physicians. Another red flag is, are they filling in multiple pharmacies? We have patients at my hospital who fill their opioids in one pharmacy and their blood pressure medication in their hometown pharmacy. Why? Because their hometown pharmacy in rural North Texas doesn't cover the opioids. Is that going to raise a red flag? The other aspect are the cutoffs of dosing criteria. In palliative care and pain management, we use oral morphine equivalents as a surrogate marker to equalize how much opioids we're giving and therefore get a general sense of how much the patient is receiving. Does the cancer patient, does having cancer justify a higher OME? Does having significant osteoarthritis with the inability to use other medications justify a higher OME? Those are things that we need to vet out. The last point I'll make is that while you did mention hospice patients are carved out, cancer isn't the only life-limiting illness that has associated pain or associated conditions where opioids could be useful. So many advanced lung disease, for example, may benefit from judicious opioids. Emphasis is judicious in terms of controlling their dyspnea and the suffering they're experiencing. So I think it's a good starting point. I think the rules are justified. I think safety is key and fundamental, and it would be hard to argue that. But it's how we apply those rules, and it's how we apply those surrogate markers and still using clinical discretion and what aspects are going to be available to us. Now, my concern is it could be argued we have already pathways by which we can negotiate or navigate the prescribing of a medication that we feel is justified for a patient, but another party may feel that it's not justified. That's called a prior authorization. I'd really hope that the utilization of the PMP doesn't create another overlay of prior authorization and having to justify while our clinical discretion and decision is to prescribe this medication for this particular patient.
And I'm so happy you brought that up. And I think you were alluding to this. What are the unintended consequences, all right? As soon as you put scores up there, they're almost like SAT scores. You know, are we in, are we out? Is somebody else going to judge this? Be it a plaintiff's attorney looking at it, being it a prior auth person looking at this. And so this overdose risk score, the ORS, is bothersome because it's there every time. It's based on one study, I think, in 2015 in Ohio, okay? So that's a very specialized database and a specialized area. How does it apply to Texas? But yet, if my overdose risk score is high, does that mean that I'm inappropriately prescribing and someone's going to say, sorry, doc, I'm not going to pre-authorize this, or I'm not going to dispense? And so that's very worrisome, and that was one of the things that was talked about at our initial meeting, is the fact that we have these scores, should they even be there? Maybe they should need to be available, but don't pop them up there, you know, for anybody to indiscriminately use without knowing what they are, without having clinical studies or data really showing what they are.
Right.
And the discretion of what the patient, that individual patient, is dealing with. And that's the key.
Yes, sir.
We want safety. We want protection of our loved ones and our patients. But we also want protection from suffering. So it's how we balance that, and that's the key.
Stay tuned for more. For more information about this topic and more, visit dallas-cms.org.